in the UK, it's called boogies. So I will toggle between the different continents on the words I use. So here you have a lean set of adipocytes on the left. And then as they start to basically plump up with more cellular weight, you can see that macrophages, the green boogies, come around looking, saying, hey, what's going on here? It doesn't look right. So they are investigating, and then they say, listen, and local cell death. It's just a part of the inflammatory cascade. So there is also another mechanism happening here. Those adipocytes are not just getting plumper by accident. It's many times related to a calorie surfeit. So what these cells and the adipocytes are actually trying to do is protect themselves from gluco and lipotoxicity. So this nutrient overload is damaging the endoplasmic reticulum. That's leading to more inflammation. And the whole cell, the adipocyte cell, is creating basically these caps, okay, that are trying to say, please stop, stop, stop. We can't take any more glucose. We can't take any more lipids. Okay, it's a protection mechanism, insulin resistance. It's not just some random thing happening. It is the body's way of trying to prevent gluco and lipotoxicity. Now that inflammation alarm is happening more than just in the adipocytes. It's now getting systemic, and now other tissues and organs are starting to feel the same burden of the calorie surfeit causing inflammation and cell death. And so glucotoxicity and lipotoxicity looks like fatty liver when you're dealing with the liver. And you can also have it, just like fatty liver progresses to cirrhosis with hepatocyte death, same mechanism that's happening. Guess what? Same mechanism in muscle cells. So in our skeletal muscle cells specifically, you will see cell death after inflammation. You'll see fatty deposition. I mean, think about the cows that are raised for food consumption, how they have marbling. So that's the fatty deposition. And in humans, you can think about how people become sarcopenic as they become more and more insulin resistant. Okay, same phenomenon. Body or tissue, I should say, trying to protect itself from glucolipotoxicity and causing a local inflammatory response. So that's your paracrine effect. And then it can go viral, if you will. It becomes an endocrine response when it starts targeting other tissues in the periphery, whether it's liver, muscle, bone, brain. It's just wherever, whatever is happening there in the visceral adipocytes can happen in other tissues. Now, if you didn't like my story with the eggs and the boogers, you can look at the medical words here. It's early in the morning, so I thought storytelling would be a better way to warm up. So these words are just going to be the synopsis of what I just said. If you're more of a picture person, it's the same thing here. You're getting this local and systemic pro-inflammatory response coupled with insulin resistance, all coming back to this protection mechanism against gluco and lipotoxicity. Here you see how the blood vessels, our arteries, are specifically getting caught into the loop of fatty deposition and cell death. So you're going to see leaky blood vessels, fatty deposition, and you're going to see damage and pro-atherogenesis. Now, this is something I explained in AFMCP if I was your teacher for the cardiometabolic module, and that is the physiology behind the insulin receptor. So I call it the lock and jiggle. So you have to have insulin lock into the insulin receptor up at the top. I'm going to call that the goalpost that you see. That's the lock. And then there's a phosphorylation cascade called the jiggle that then kind of creates this cascade that ultimately causes the GLUT4 channels to open up, the GLUT4 receptor come up and open up glucose channels for glucose to come into the cell so that it can be then the glucose utilized for energy production by the mitochondria. Now, of course, insulin resistance is where that receptor isn't as sticky, it isn't as responsive. And so not only do you fail to get glucose into the cell for energy production, but you also now are rendering a hyperinsulin state in the periphery. So you get hyperinsulinemia as well as hyperglycemia in this mechanism. So what can we do about that? Well, there are many nutrients that have been shown to improve the lock and jiggle, things that can improve the GLUT4 transporters coming up towards the periphery. You see these listed here, things like vanadium, chromium, cinnamon, alpha lipoic acid, biotin. Another new player, if you will, relatively new player, is berberine. Berberine is a botanical that can dampen all primary pro-inflammatory signals. How nice, because remember, we always, if you remember my anchor concept, it is that what precedes these comorbidities, many times it's insulin dysfunction. Well, what precedes the insulin dysfunction many times? Inflammation or toxicity. So if berberine is helping the primary inflammation issue, it's then going to address the downstream insulin resistance, and all the comorbidities stuff that can happen. So consider berberine in your option. So again, this is just showing you if you can reduce inflammation up here at the top, then you can reduce a lot of cascade effects downstream. Berberine specifically seems to act in the microbiome layer. It modulates the gut microbiota. So it might create some immune tolerance, therefore not rendering as much inflammation. So consider berberine as one of the tools you can use to support insulin dysfunction and insulin resistance related comorbidities. Berberine seems to increase insulin receptor expression, so the lock and jiggle works more effectively, and it also improves the cascade with the GLUT4 transporters. So that's one mechanism by which you can start to get to the root cause of many of the conditions I talked to you about. When you see that paracrine and endocrine, glucotoxicity, lipotoxicity, organ damage, okay? Berberine. Now, another mechanism for you to consider is leveraging NF-kappa B. So NF-kappa B, you probably know this from Bob Roundtree with the funny dance that he does during AFMCP, but the goal is to keep NF-kappa B settled, grounded, because as long as he or she doesn't translocate, then a host of inflammation signals do not get triggered. So our goal is to keep NF-kappa B grounded. How can we do that? Well, we can use NF-kappa B inhibitors. So I'm starting to develop a little cheat sheet list for you in this presentation of treatment options for any host of comorbidities related to insulin dysfunction. So you can directly affect insulin resistance through the ones in that aqua color, or you can indirectly help insulin resistance or insulin dysfunction by leveraging things against inflammation. Because if you remember, again, I'm going to do a lot of repetition, that insulin dysfunction is what then causes all those comorbidities. But what causes insulin dysfunction is generally inflammation or toxins. So our goal is to address things that are pro-inflammatory, right? Because if we can address things that are pro-inflammatory and we can nip the insulin dysfunction in the bud, then we can prevent all the downstream organ damage or organ dysfunction. All right, let's move on to the next section that you can leverage for reducing the inflammation and insulin soup damage, if you will, that the genes bathe in. So this is the one you'll hear often in our presentation, and that's because, and actually in functional medicine, I mean, if you don't know the answer, just fix the gut. That's usually where you need to go. And this is the pathophysiology for why we do that in cardiometabolic medicine. So if you look at the bottom left with me, if you have that poor or sad diet, right, that Western modern diet with bad fats, it will directly damage your microbiome. That change in microbiome can render increased intestinal permeability. And now lipopolysaccharides are able to translocate or leak into the bloodstream. The immune system says, oh, no way, buddy, you're not supposed to be in here. You've got these endotoxins in there, and now there is a local and then systemic inflammatory response. That inflammation is going to drive the insulin dysfunction, which is going to drive the metabolic disorders that come thereafter, whatever the person's genetically prone to. It just gets clicked on epigenetically. So remember, if you can quell the inflammation in the microbiome, meaning create this tolerant and strong microbiome, you can reduce the inflammatory tone of the entire body. And when you reduce that, it's been shown that that sets the insulin sensitivity. So the lower the inflammation, the higher the insulin sensitivity as it relates to the microbiome. So surprise, surprise, it's been shown that probiotics are associated with improved insulin sensitivity. So the right probiotics will create immune tolerance. Microbiome strength and modulation is occurring with probiotics. And so insulin sensitivity is preserved or regained based on where you are. So I want you to think about that as another indirect mechanism or treatment option for leveraging cardiometabolic health for patients. And I tend to be, as a firstborn girl of immigrants, I always tend to look for deals, if you will. So I look for, when I pick in this list, I'm looking for things that could get me a buy one, get one free or buy one, get two free benefit. So probiotics, obviously, I'm going to use in someone who might also concurrently have irritable bowel syndrome or food allergies. So I look, and if they also seem to have insulin resistance issues, then I might pick probiotics over NF-kappa B inhibitors. But if they seem to have a lot of neurocognitive issues, I might start with the NF-kappa B, right? So that's the way you can kind of decide which ones to pick. Now, remember that anchor slide that I talked about in the early part of yesterday about how a bad diet, if you will, or a sad diet is not just a quality conversation, it's a quantity conversation and an immune conversation. So this is, again, just reminding you that when you fix the gut by really feeding it well and reducing its inflammatory tone, you get a whole host of other preventative benefits. You stop all these blue arrows, or at least reduce the strength of the dysfunction of those blue arrows in this diagram. And you can see that ultimately can reduce the risk for obesity, diabetes, and metabolic syndrome. Now, again, if you like words, this page here has the words related to that picture that I just showed for your reference. Really what I'm trying to do is drive home that metabolic endotoxemia, or just managing the microbiome, is a powerful, powerful, powerful tool to be able to help your insulin resistant and or cardiometabolic patients, okay? There is so much data that tells us that we cannot just make the conversation about eat right and exercise. It's so much beyond that. So the more that we can improve the gut microbiota, we can change inflammation signals through proper diet, exercise, stress management, sleep, all the other things we've been talking about, fixing the gums and the teeth. The less the inflammation, the less the insulin dysfunction, and therefore the less all those downstream disease effects. So what we want to just make sure you know is go to the gut. Make sure that gut microbiome is happy and tolerant. It's one of the most potent ways you can influence a healthy cardiometabolic phenotype. And just as an aside, although it was a bigger thing, I want to say a decade or so ago, non-caloric artificial sweeteners, okay? Artificial sweeteners, what they seem to do is they might be non-caloric. And so people are, maybe tricked into thinking, oh, it's zero sugar. But here's the problem. These artificial sweeteners can actually interfere with healthy microbiome compositions and actually induce type 2 phenotypes even more. So even though you think you're getting the benefit with no calorie, you're actually going to increase your risk for diabetes more through its effect on the gut microbiome. All right. we've made it through objective one. Hopefully, what you've learned is that insulin and inflammation and adipocytokines and all the other things that happen in the endocrine response affects many organs. So let's now start to look at emerging risk markers. Okay, now I know that we've talked a bit about TMAO. Just want to point it out again that that's still a relevant concept here with the gut and insulin resistance. So we want to make sure that you look at TMAO not as the end all be all, but another emerging biomarker that could give you a clue about microbiome health. In general, for me, I look at elevated TMO as a way for me to help the patient recognize you got to change what you're eating. Most of the times, it's that I'm helping patients reduce unhealthy animal proteins, generally unhealthy animal proteins, and increase their plant-based nutrients. It's generally how I use it in a standard medical practice. So for those of you who are in an insurance-based practice, if you do get access to this test, that's generally what I'm using it for. All right, now another emerging biomarker, okay, and it sounds funny to call it emerging because it seems so obvious. So is insulin, okay? Our standard of care is very centralized around glucose, fasting glucose, 2-hour postprandial glucose, A1C as a measure of glucose. We really are glucosocentric. And we need to, if we're really trying to be preventative and proactive, use insulin as an emerging biomarker. And as you remember, we talked yesterday that a fasting insulin in the bottom or the first quartile of your reference range for fasting insulin might be where you want to go. And for us in the US, that tends to be between 5 and 7 as a unit, okay? Now, this is a summary slide just to kind of recap some of the things we've been talking about. So notice that this says pathophysiology of type 2 diabetes. So type 2 diabetes can happen from insulin resistance. It can also happen from mitochondrial problems. So pathophysiology of type 2 diabetes could be because your pancreas is not secreting enough insulin. So again, this is that little 20% that I talk about. Majority of the people who are getting type 2 diabetes, it's from insulin resistance, I would suspect. Okay, from a hyperinsulin problem. But there is this group of people who have damaged mitochondria and they are not outputting insulin, so their blood sugar rises and they get type 2 diabetes, okay? Then the question is that if there is a problem with pancreatic beta cells, why is there a problem? Is it, and I'm going to talk about that in this lecture here coming up. Now, could it be that the glucose is going up because the muscles have insulin resistance, so they're not able to capture and bring in glucose? So is it the liver that's hepatic insulin resistant, that it cannot take in glucose for energy? Like why is this glucose running around in the bloodstream? That's what this is kind of paraphrasing. So contributing role, you got to look at the adipocytes. You got to look for visceral adiposity. You've got to see, is this person just a big belly fat inflammatory like catalyst? What can we do to reduce that? Is the inflammation coming from the microbiome? Is it coming, like, now even the kidney can play a role in this, right? Like perhaps the kidney has increased glucose reabsorption. Why? Could it be because of an oxidative stress hit to the kidney? Or could it be in the HPA axis, the hypothalamus pituitary and adrenal axis, where you're getting this cortisol response and this sympathetic nervous system response that's generating inflammation and driving the blood insulin and blood sugar disturbances? I'm going to talk here about the liver a bit here, okay? Because it's a common player for many people. Even if they don't have fulminant fatty liver disease, it's generally a subtle and common player for people with cardiometabolic dysfunction. So remember, the liver is here in our anchor slide. You've got the visceral adiposity causing inflammation and insulin resistance with atherogenesis. And the liver is kind of like this innocent bystander that gets caught up in the drama, and it's happening before sometimes the atherogenesis starts. So we can look to the liver to find earlier cues of cardiovascular risk. Okay. How can we do that? Well, let's understand some liver biochemistry. So in a healthy liver cell, hepatocyte, when you have increased insulin being secreted because there was a meal that required glucose to be absorbed, what you expect if the insulin receptor is working is that the glucose would go in and then the glucose would get oxidized and turned into energy. But here's the problem. When the hepatocyte has insulin receptors that don't work, you've got that insulin on the outside and the glucose never made it in. But what happens also on the inside of the hepatocyte is it was assuming that the glucose was going to get in. So what it does is it turns off fatty acid oxidation, thinking, guys, we don't need to burn our fatty acids. We've got some glucose coming in. So when the glucose is not there and you're not burning off fatty acids, very common for people to feel fatigued because there's nothing burning for energy. But here is the secondary sequela. Where are all those fatty acids going, right? Well, the liver may try to repackage them as triglycerides. Sometimes they stay in the hepatocyte, or sometimes they get shifted out of the liver into the bloodstream as VLDL, very low density lipoprotein. You might just see it in a standard lipid panel as a high triglyceride shift. So when all of us are talking about getting a triglyceride level to around 70 as your 8+ goal, when I start seeing triglycerides ooching up, I don't wait till they're 150, even though that's the cutoff for our labs. When I see it at 150, I already know they are shunting triglycerides out of the liver. So that will happen many times before I will find an impaired fasting glucose. So look at your triglycerides, your fasting triglycerides as an emerging or early biomarker of insulin dysfunction. So this is another diagram that basically says that if the triglycerides that are being created because the fatty acids are being oxidized, then they can either stay in the liver and then that creates the steatosis or the fatty liver, or they can be pushed out and they turn into lipoproteins. We're going to talk about that in just a second. But basically, the system is like, what the heck are we going to do with these fatty acids? We can't, it's like trying to shove them into places because nobody wants them. Like the liver's like, I don't want them. Okay, I'll keep some here. I'll be fatty here enough as I can. Sometimes the liver's like, I don't want them. I'm going to stick them out into the blood vessels. And so then the blood vessels, the arteries are like, well, I don't want them. I'll put them underneath my endothelium. And so that's how you get atherogenesis. The muscles are maybe like, I don't want them, but I guess I'll take some. That's how you get the fatty streaks in your muscle. You with me? Yeah, that's how it's happening. So this diagram talks again about how when that liver is getting bogged down with steatosis, now an inflammation, there is like this feed forward cycle inside the hepatocyte of inflammation. It's damaging. If you remember the white eggs and the green boogies, remember the same thing's happening here in the hepatocytes. You're getting cellular death. You're getting fibrosis, which is just an extension of what happens when we don't address the core issues for fatty liver, which is inflammation and insulin resistance. So what happens? I'll look for rises, subtle rises in AST, ALT, GGT. Remember, that is a liver-based enzyme. GGT, I call my smoke detector. It's telling me how much oxidative stress is going on. Obviously, I'm going to look at HSCRP. I like to look at ApoB to see, like, what is the output of this liver? Is it starting to dump excess fatty acids through VLDL and ApoB or triglycerides? And how it picks that is just genetics, honestly. So I look for liver markers to tell me what's going on in the liver as a sign of what's going on everywhere, because that might be the genetic weak spot of the person. Some people are genetically weak just in terms of their lipid profiles. So I can look for something called metabolic dyslipidemia. You know this as high triglycerides and low HDL. You can specifically look for a ratio, an optimal ratio is 3 and lower. But as it starts going from 3 to 5 and then 5 to 8, like 8 is almost pathognomonic of insulin resistance. And you're just kind of ooching, becoming more and more insulin resistant, you can consider, as the number is increasing for that trig over HDL ratio. That is a simple, easy way to kind of screen for insulin resistance. Now, there are people who look 3.0 on this, but still have insulin resistance. So this is not like the one and only test you do. This is a way to find those people who show their insulin resistance through their lipids. But remember, like for me, when I had PCOS, my lipids looked beautiful. I didn't have this issue, but that's because genetically, I don't express my insulin resistance through my cholesterol and lipid panel. I express mine through my hormones, through insulin, estrogen, and inflammation. So I'll talk about that here. So don't look for one test or ratio to be the indicator that, oh, they've got it or not. You're just looking to see, could this be the place where I'm going to find the clue? Okay, like Mrs. Peacock in the observatory with a candlestick. Okay, that's what you're kind of doing. Now, I alluded to this yesterday in the Q&A, and somebody asked a great question. Like, if we can't order LDL particle, how can we know if we need to do something about the LDL cholesterol? Now, let's just back it up a bit and just say that, let's say you can order LDL particle. It is wonderful because in the face of insulin resistance, LDL cholesterol is less and less reliable because it's almost dependent on you having insulin sensitivity to have an accurate LDL cholesterol. If not, then it actually behooves you to get a particle number, because this is what's happening. Now, if you look on the top row across with me in a, I won't say normal, because normal people or average people are actually quite unhealthy. So let's use the word healthy. A healthy person has VLDL that looks to be this number and size, okay? And there's the LDL and the HDL. But now look what happens when you get insulin resistance. These VLDLs start to pump up with triglycerides. That's why they're fattening up. It's the lipotoxicity. So if you start looking at the VLDL3 number in a lipoprotein profile, you'll see that that number is creeping up. And there's more of them and their size is bigger. Now with LDL, what happens is that the cholesterol amount within the top and the bottom is the same amount. Meaning, like if I pop all these water balloons, it's the same amount of LDL cholesterol. However, in insulin resistance, that same amount of LDL cholesterol is repackaged in small, dense LDL. So actually, the particle number is higher when they're insulin resistant. So cholesterol is the same, whereas the particle number is higher. And small, dense LDL is more atherogenic. Now, I get that there may be some of you who cannot or do not have access to this testing, or maybe your patients cannot afford it. And that's why we answered the question we did yesterday. So look for other clues of insulin resistance and treat the root cause, right? Look for inflammation, treat it. Look for other signs of insulin resistance, treat it. Because whether or not you have access to knowing the LDL particle, there should be something in your head that says, man, even though this person's LDL cholesterol looks good, they have tons of inflammation and insulin resistance, I can't be sure that they don't have higher particle number. In fact, you might want to assume that they do, just to be safe. Okay, the other thing that happens in insulin resistance is that the HDL, or the healthy cholesterol, tends to become small. So that's not very good because the efflux capacity of HDL is lessened when it's smaller. So we like the larger HDL, if you will. So I've put together a list of labs that, you know, in general, if you should know, should meaning if you can know, you have access to getting these tests, it would be lovely because it would give you a great solid indication of what's going on with your patient from a cardiometabolic perspective. Okay, now I am not one of these people that orders 50,000 tests just to have a bunch of information. I find that that really is too much information for me and the patient. It kind of takes us down rabbit holes. So I only order these other tests here if the timeline tells me I should look into these things. So I also order these things in addition based on the patient's ability to change behavior in response to the test. So I had wonderful teachers in medical school, and one of them said, do not order a test that's not going to change your management. Yeah. So if you were going to have them go gluten-free, assuming that they're not celiac, do you need to do the gliadin antibodies? Well, you can say, well, if that patient needs to know it before they go gluten-free so that they stay off of it, you do. But some people are like, that's too expensive of a test. I'm willing to do the standard gold standard test for gluten intolerance or gluten sensitivity, I should say, which is the elimination provocation. Why do the test? Okay. So I like to use that logic because for 9 years I was in the insurance system and I had to use those kinds of filtering mechanisms to be able to decide, is it worth the money for the patient in case it's not covered? All right. So here we are in our decision tree. What I've been focusing on with you is the insulin aspect. So you've got some summary slides here. Remember that it's not like insulin doesn't live or visit the other parts of the cardiometabolic risk pattern family. You can absolutely have other parts going on. So let's talk about this other situation, which is mitochondria. If you remember, I talked about how a majority of what we're talking about is insulin resistance and high insulin. But there is a group of people that actually has a low insulin issue. Let me show you how we find them. Okay, this is just a study so that you have some confidence that this is all evidence-based guidelines and or recommendations and science that we're giving here. So now let's talk about the mitochondria. I'm going to simplify this article. You're welcome to read that article. I love to simplify things and I love to use pictures. So the article basically says there's two types of mitochondrial dysfunction. Many times you want to think toxins as the reason why mitochondria get damaged. It can also be genetically passed along. So the two types are you don't have enough mitochondria, so that's a quantity issue. The other problem is it's a quality issue. You got plenty of them. They just don't seem to work very well. So that they don't have high output or at least normal output. Now, how does this play out in the body? Okay, let's talk about the first issue, which is the quantity issue. So out in the periphery, in your muscles, in your adipocytes, in your liver, okay, you have mitochondria in those cells. And it's their job to energize that lock and jiggle, okay? So if your mitochondria are in the right number, then you've got plenty to energize the lock and the jiggle of the insulin cascade. But if you don't have enough, then if you will, the lock and jiggle is kind of limp. It doesn't work as well. Well, if it doesn't work as well, then the GLUT4 transporters don't make it up to allow glucose in. So what happens? You get what we've been talking about for 80% of people. They get high insulin and high glucose, okay? So just know that if your mitochondria are not in the right amounts, okay, and you've probably learned from other advanced practice modules, different ways that you can increase mitochondrial health. But if you don't have enough, it can create hyperinsulin and hyperglycemia, and it can basically create insulin resistance. Now, that's what we've been talking about. That's how mitochondria contribute. Now let's flip it. Now, in the pancreas, what seems to occur is that the mitochondria in the pancreas are in charge of energizing the ability of the beta cells to secrete insulin. So if you see in this diagram, here's insulin, and there is like an electrical cascade that generates the energy to kick that insulin out of the pancreatic beta cell, okay? Well, if you have limp mitochondria in the pancreas, then there's just not enough juice going through that electrical chain, and the insulin doesn't get secreted. Now, what happens if insulin isn't secreted? Well, it can't sit on the lock and jiggle mechanism. But in this particular scenario, if insulin isn't secreted, walk with me here, you have a low insulin state, but you'll still have high blood sugar. I'm going to pause and say that again. If the mitochondria are not working optimally in the pancreas, specifically in the pancreatic beta cells, then they do not have the energy to secrete insulin. So you actually end up with a low insulin state, but you still have the high blood sugar because you don't have enough insulin to do the lock and jiggle and open up the glucose channels. So you still have the glucose issue, you just don't have the high insulin problem. Okay, that's how it can contribute to type 2 diabetes without having insulin resistance. Interesting, right? So here it is in summary. If you don't have enough mitochondria, which seems to be the problem in the periphery, you get insulin resistance because the lock and jiggle isn't working well. But if you do not have the mitochondria working well in the pancreas, especially in that beta cell, you don't secrete insulin. So you still get hyperglycemia, you just don't have high insulin state. I know your brain should kind of be hurting right now, but hopefully it's coming together slowly but surely. Big themes. So let's just see if we can nail down these themes a bit more. We're going to do a little bit of redundancy here. And this is how I want you to look at this next section. Do not try to feverishly read every single thing on the slide. If you notice, I tend to highlight the key parts of the slides in a different color, so it's easy to grab the main point. What's going to happen now is I'm going to show you how the themes of things that I've been talking about, whether it's lipotoxicity, glucotoxicity, inflammation, insulin dysfunction, mitochondrial dysfunction, gut dysfunction. I'm going to show you how all of those are leading in to different diseases, similar diseases. And again, it's just the unique genetic code that determines when this little smorgasbord of drama that I've just mentioned starts to hit genes, it releases this host of comorbidities. Okay, so let's see. Look at this. This is an article that connects mitochondrial dysfunction with type 2 diabetes, and poor maternal nutrition can prime it. This one is talking about how fatty liver is associated with lipotoxicity, right? That's that increased fatty acid, oxidative stress, which remember is the byproduct of inflammation, ATP depletion, and mitochondrial dysfunction. Do you see the same themes? Look at this one. Here's fatty liver and the gut dysfunction and probiotics. This is a pharmaceutical, VSL number 3, that when they gave it to rodents with fatty liver, it improved their fatty liver. It reduced ALT. It improved insulin resistance. It reduced inflammatory signaling, right? Another one with fatty liver and fixing the gut. You put the probiotics in, woo, type 2 diabetes and fatty liver get better. This is the mechanism for fatty liver and probiotics, if you wanted to take a look at it. Fatty liver, exercise, and mitochondrial function. So we know that exercise, or you will know, exercise is one of the most potent anti-inflammatory signals your body can have. So it is very effective at reducing inflammation, and then you kind of juice up your mitochondria and you're supporting fatty liver. Here's fatty liver and the mitochondria again. Okay, so let me back up to say, did you kind of get that it's the same themes over and over that relate to these metabolic chronic diseases, right? Inflammation, insulin resistance, mitochondria, gut. Same things you keep hearing me say. Okay, so now let's talk about some other metabolic diseases that you might not be thinking are metabolic. So we're going to specifically talk about hormone-related metabolic dysfunction. Specifically, let's talk about breast cancer. So before I get started, let me ask a few questions for you. And I'd love for you to chat it up in the chat feature so that you guys can see what you're thinking, okay? So we're going to talk about PCOS and breast cancer in this hormone section. So what do you think is the primary hormone driver of the oligomenorrhea or the amenorrhea that we see in our PCOS patients? Just going to pause for a bit so that you can take a look and chat it up. Now, I'm blind to what you're saying in the chat room, but I would assume that some of you are kind of saying, you know, it's that testosterone, it's that high androgen. And of course, I've kind of set you up to say that because that's not the answer. We're going to find the answer out in just a bit. All right. How about this question? What do you currently utilize for breast cancer prevention? Now, it's a little bit of a trick question too. I didn't say, what do you currently utilize for early detection of breast cancer? Oh no, I'm a lot more, what would I call it? Like bold about what I want. I want prevention. Forget early detection. Now, I'm not saying that I don't believe in early detection. I'm just saying, why go for early detection when you can actually prevent it? What do you use to prevent breast cancer? And last, but certainly not least, do you commonly use, do you incorporate a cardiometabolic approach to optimize the prevention of breast cancer for your patients who are at risk? Which, by the way, if you're female, you're kind of at risk. Do you all commonly use the cardiometabolic approach as breast cancer prevention? Because I'm here to say it is a wonderful strategy to prevent breast cancer, not just detect it early. So let's learn a little bit about why. So here's our friend, insulin resistance. I guess he's not such a friend. He's a frenemy. He is a frenemy because, listen, as I said in the beginning of this lecture, insulin resistance is just your body's way of trying to protect you from you and your habits. So it's not a complete enemy because it's actually trying to help you. The body generally is trying to help you. Even when it's hurting you, it's doing it in an effort to help you. I mean, think of fever. It's a classic example of the body hurting you to help you. Insulin resistance is actually not that different. If we would give the body what it needs, it would stop the insulin resistance. Well, give it what it needs and take away what it does not need. So in this next segment, let's talk about how insulin resistance drives estrogen-related cancers like breast, ovarian, and endometrial. Okay, notice cervical is not in here. It's not the right mechanism. These estrogen-driven cancers are associated with insulin resistance. In fact, if you have this trinity of obesity, insulin resistance, and inflammation, it's associated with a poor prognosis in early stage breast cancer. So look for that white adipose tissue or that visceral adiposity, okay? Look for it as early risk markers for breast cancer. Did you know that there are racial disparities with breast cancer, that Black women gain more weight and therefore have an increased mortality as compared to white women? And that's because with that visceral adiposity comes insulin resistance and inflammation. So they have that much more driving their breast cancer. Did you know that just straight inflammation biomarkers are associated with breast cancer? And therefore, surprise, surprise, if you leverage exercise, a potent anti-inflammatory, the prognosis for breast cancer improves. So I want you to remember, even though there is this tendency when women with breast cancer are like, you know what, eat your ice cream, you're going through chemo, I want you to consider encouraging them to get lean, like figure out a way maybe that they could enjoy a walk if possible, as a way to help them turn off the signals that drive their breast cancer. Because there's a window of opportunity. It shows, results here in the US show that 35% of cancer survivors remain physically inactive 5 years after diagnosis. Many times cancer becomes this badge that people almost quit with. And we've got to make sure they know, like, listen, you've survived. Let's keep this from happening again. Let's get you moving and leveraging something as cheap as exercise and movement. So in breast cancer prevention, I really want you to think about promoting this cardiometabolic food plan because it's anti-inflammatory, it's low glycemic impact, so it's going to reduce risk for insulin resistance, and it's phytonutrient rich, which is really good for the liver, which helps with detoxification as a mechanism to prevent breast cancer. Now, let's just be real specific with breast cancer. If they're diagnosed with breast cancer, and generally I'm speaking about estrogen receptor positive breast cancers here, being obese increases the chances of a poor final outcome, 2.5 times more likely to die. 2.5 times more likely to die if they're in the highest quartile of BMI in this study. That's 250%, people. Okay, so look at people's body composition. Use this toolkit item. Figure out if they have visceral adiposity. Just look at them. Are they apple shaped? Help them lose the apple. Now, with breast cancer and diabetes, not just obesity, now I'm talking about breast cancer and type 2 diabetes. When they have those two things, there's increased mortality and increased risk. So I'm just trying to plug that. Consider using the cardiometabolic approach to be able to prevent and treat your breast cancer patients, okay? Now we're gonna flip from people who are diagnosed with breast cancer, and now we're gonna talk about true breast cancer prevention. So primary prevention, somebody who's never had the breast cancer or doesn't have it. I should say doesn't have it. Even if they've had it before, this is the way we wanna prevent the second occurrence or the first occurrence. So here is the big money anchor slide. Insulin promotes breast cancer because it elevates estradiol and it elevates testosterone. And why is that a problem? Well, first, let me just remind us that 70 to 80% of breast cancers are sporadic. They have nothing to do with family history or BRCA1 and BRCA2. And although there sometimes is an emphasis on family history and the BRCA gene, 70 to 80% are sporadic. You know, in my mind, I'm wondering, are they sporadic or are they just mediated by the obesity and diabetes epidemics, right? So if your patient is a postmenopausal woman, consider using BMI as a way to help her understand her breast cancer prognosis. Use that. But if they're premenopausal, it seems that waist to hip ratio more closely associates with future breast cancer risk, okay? In the end, just optimize body composition as much as possible is what I would say. Really reduce the apple phenotype. Now, this is the Mac Daddy biochemistry slide, okay? This is the anchor slide that I want you to pay attention to because it really starts to tell you what happens with insulin and hormones. So let's say we start with this picture of central obesity, visceral adiposity, apple subtype, whatever you want to call it, okay? Belly fat. This central obesity pushes androstenedione, which is A2. It preferentially tells androstenedione, hey, why don't you go turn into estradiol? So this fat drives estradiol production, okay? But this fat also, through a different mechanism, is going to reduce insulin sensitivity, so therefore increase insulin resistance, and you're going to get that high insulin state, which, by the way, insulin is trophic, okay? Trophic, meaning it likes to make things grow, just like our friend estradiol. So if you happen to have some neoplastic cells around, you've got an estrogen trophic signal and an insulin trophic signal. Not a good combination. The other thing that seems to happen is that, you remember we talked about how the liver starts to get kind of caught up in the whole inflammation, insulin, problem, drama. Well, the liver is in charge of secreting sex hormone binding globulin. So as it starts to suffer from inflammation and insulin resistance, sex hormone binding globulin levels may drop. Well, then there's less to bind up that estrogen. So there's actually more bioavailable estrogen. There's more of it available to stimulate growth. Okay. So put that all together. You got this insulin that's trophic. Insulin also likes to promote blood vessels. So you got like a rich blood supply. You're telling things to grow. You got a bit more estrogen than you need. And you put that in around some neoplastic cells, and you got the makings for breast cancer. You see that? So this is just reviewing what I just said, that insulin increases the supply of bioavailable estrogen, right? By increasing synthesis of estrogen and reducing sex hormone binding globulin. And by the way, did you know that insulin also will increase testosterone? And testosterone, it binds to sex hormone binding globulin even stronger. So it kind of like is binding up what little there is. And that means there's even more estrogen floating around to stimulate an estrogen receptor positive breast cancer. Okay. Now, just make sure you know that I'm talking about women here, right? Men actually have less risk for diabetes when their testosterone levels are higher or normal. Okay. High testosterone in women increases breast cancer risk. Why? Because it independently increases risk, and because it binds up sex hormone binding globulin, it makes estrogen more available to stimulate breast cancer growth. So testosterone, like especially for people who are doing bioidentical hormone replacement therapy, more is not better. Okay. We do have to weigh the benefits against the risks in our patient. So this is my big picture slide that basically is saying, hey, listen, as you start increasing that visceral fat, it's going to create insulin. That's like a feed forward cycle here. And then that high insulin is going to drive high estradiol. And in an estrogen receptor positive breast cancer cell, not a good combo. Okay. All that insulin, all that estradiol, it's going to be a problem. Now let's flip to this other less common, but seemingly increasing type of breast cancer. It's that triple negative breast cancer. Now these people just have a different derivation of the same issue. So for them, insulin is actually driving androgen excess. So they've got this high insulin. And again, why is that happening? Genetics. That's just what they do when they see insulin. They drive more androgen. So they have high androgen, high insulin. They don't aromatize that androgen into estrogen. So they got still a lot of androgen. And because you don't have the estrogen around, the cells, the breast cancer cells do not differentiate. So they stay undifferentiated or poorly differentiated. So that low estrogen supply actually is what's driving that undifferentiation, and then creates this triple negative subtype. But again, it's still coming from the same core. It's the insulin and the inflammation. Okay, let's talk about PCOS. It's kind of the more of the same. I don't know if you kind of get what I'm doing, but I keep driving everything back to insulin, inflammation, toxicity. Those are the themes here. So let's see how it relates to PCOS, another increasing issue amongst many women. So as you probably know, PCOS is very related to being overweight or obese, and it's very related to insulin resistance and high insulin. In fact, it's almost universal that somebody with PCOS has insulin resistance and high insulin, okay? Universal almost. Even when they have normal body weight. You remember in our BMI conversation, like people who are Asian, Hispanic, many times look perfect on a BMI chart, but they're packing around some visceral fat. And the reason they don't look overweight is because they've lost muscle mass. They're sarcopenic, they're skinny fat. Remember, you find them here on your body composition. Like they look good until you measure their fat or their waist circumference. You're like, ooh, you've been hiding some visceral fat on me. And remember, visceral fat is the driver of the inflammation that drives the insulin resistance, that drives the drama. So again, surprise, surprise, even when people were overweight or had a proper waist to hip ratio or proper lipids, if their CRP was high from something else, stress, gut, I don't know, whatever else could drive inflammation, it still drove the PCOS. So it's not always related to visceral adiposity as the cause of the inflammation, okay? It's just common. So hopefully you're getting this theme about inflammation and insulin resistance. You should kind of be tired of me saying it at this point, but at least I will feel confident that you've got that in your head. Now let's talk about insulin resistance. Most of the times when I've been talking about it, I've been talking about peripheral tissues like the muscle, the liver, the adipocyte. But did you know that even though muscle and fat can become resistant to the insulin signal, the ovaries don't become insulin resistant? It's almost like God or evolution said, we can't let this mechanism affect reproduction. So what happens? The ovaries, even though there's insulin resistance going around in the body, the ovaries can still process that insulin signal. So they're like, oh my gosh, where's all this insulin coming from? Okay, I guess we have to respond. And what do? High insulin drives high androgen in people who are genetically predisposed. So you got someone with the genetics for PCOS, and then you put me in a stress state called medical school, and you put me in a stress state that has me not exercising like I used to and eating fast food. And then, like I said, I have an insulin resistance, an inflammation gene predisposition. In fact, nobody in my family that I know of has PCOS, but that's just the way my genes decided to express the inflammation and insulin resistance, okay? My inflammation was from skinny fat and from the HPA axis, but it still rendered a high insulin state. And in my body, my ovaries decided we make androgen, we make testosterone. So remember that testosterone is binding up my sex hormone binding globulin. It's got a tighter affinity than estradiol. So what happens? My estradiol is more bioavailable. Well, what does that do in someone? I don't have breast cancer cells that are significant, hopefully, but what was the estradiol doing to me? It was shutting off my periods, oligomenorrhea and amenorrhea. So the answer to the question when we first started this section, it is elevated estradiol that actually creates the oligomenorrhea and amenorrhea. Okay, so the high insulin is driving high estradiol as well as high testosterone. Okay, and what that's creating just an altered hormone status, right? That high elevated estradiol is what causes the menstrual irregularities. And if we leave that high estradiol unchecked, it increases risks for estrogen-driven cancers. So for your patients with PCOS, we want to be looking for what you could do to bring down insulin and estrogen because they're at higher risk if they've been PCOS for many years, decades. This is just a diagram to remind you that just because on the left side, you've got this periphery responding to, well, I should say not responding to insulin, meaning being resistant. The ovaries are like, we're not listening. All that insulin, we're pumping out. We're continuing to do our job. Okay, so insulin resistance plays out differently in certain organs. The ovaries, it does not, you don't get insulin resistant ovaries in general. The other overlay I want you to think about for PCOS that disrupts hormones is the toxins. Things like BPA and other endocrine disruptors can exacerbate PCOS symptomatology. And listen, from personal experience, I went through the infertility workup because of my PCOS. I was actually a family practice doctor who was certified in low risk obstetrics. I was delivering babies from 14, 15, and 16-year-olds while I was silently trying to start my own family. It was one of the lowest points in my life. And this is what these women are dealing with, that they don't recognize that as they're viscerally obese, even though I was skinny fat, nobody would have called me obese or overweight even at the time. But I never realized that if I would have gotten into better shape, that would have improved my fertility. Just didn't occur to me. I wasn't a functional medicine practitioner then. And that infertility is really tied to that waist to hip ratio and BMI. So please pay attention and just give them some of these relative risk ratios. Like if they're obese with a BMI of 31 plus, their relative risk of infertility is 370% higher. 370%. That's significant. You say that to a woman and that might change her motivation to follow the cardiometabolic food plan or whatever else you request of her to do. She needs a good reason. And starting a family is a good one for many PCOS patients. By the way, like I said, none of my family members have PCOS, but my father is diabetic. He's got 7 siblings. Majority of them are diabetic. So I have it in my gene pool to be insulin resistant. I just manifested as PCOS. Maybe because I'm a female, maybe because I'm a stress monkey. I don't know. But I do know that as I'm aging and I'm getting into my little perimenopausal state, I am being very mindful of what I need to do to mitigate the excess estrogen that I had in my body for 20 years. Because not only is it going to affect my cancer survival or cancer rates, for estrogen-driven cancers, but I'm at higher risk for worsening cardiovascular events. So it's one of the blessings of functional medicine that I was able to turn off the inflammation in my gut. I was able to turn off a lot of the impact of toxic burden in my liver. I've been able to reduce, can't say that I've turned it off, the HPA axis inflammation. And we just want to kind of remind that when you're thinking about bioidentical hormone replacement in any women, just look for the Goldilocks as much as possible. Do not just shove hormones in a woman thinking they have no implication, because obviously, they do. They have benefits and risks. So although testosterone can help with cognitive performance and libido and musculoskeletal health, just be mindful that they're doing that testosterone and not increasing other risks related with breast cancer or PCOS. And this is just a call out to this other axis of inflammation, which is the sympathetic nervous system with cortisol and that HPA axis with cortisol. That was, I'm sure, one of the drivers of my inflammation that caused my insulin resistance, that caused my PCOS, that caused my infertility. So intervene. That's what Mimi is teaching us. How do we normalize the HPA axis? How can we reduce that fight, fright, flight response? So I never want you to forget that there's that middle of the matrix, the mental, emotional, spiritual. It's way too important to ignore. I've talked a lot about women here. I'm sorry, men, I've got just a little bit of information for you, although I think it's really just the same kind of stuff. Prostate cancer is an estrogen-driven cancer. So the things that I was saying about breast cancer, consider the same kind of go for prostate and colon cancer. So when you see men with metabolic syndrome and low T, we don't know if it's a chicken or egg phenomenon, but we do know that when they have low T, men with low T, there seems to be an increased risk for metabolic syndrome. And what we see is that there's this vicious cycle, because when you have low T, you get this metabolic syndrome, and that high insulin can kind of drive visceral adiposity, which then reduces testosterone, because remember, testosterone in the face of visceral adiposity turns into estradiol. It's that estradiol that'll then go on and stimulate prostate and colon and breast cancer in men. I mean, it has happened, okay? But you notice it's the same junk that you have to keep addressing on the front end. This is the diagram as it relates to men. So they can be over VAT, meaning having excess visceral adipose tissue. that leads to their high insulin state. But for them, they get low testosterone, okay? Not high like in women, but they still get that high estradiol, okay? So they still have the high insulin and the high estradiol. So all that trophic signal with the angiogenesis, and that's what can drive prostate and colon cancer risks. Remember again that low T can worsen the over-VAT situation. All right. We just finished the hormone section. So remember that when we started this conversation, we were talking about how insulin and inflammation drive many comorbidities. Just add on hormone drama as another thing that you can prevent or reduce or reverse by addressing inflammation and insulin dysfunction. Now let's talk about the brain, this so-called type 3 diabetes. The evidence shows that Alzheimer's disease seems to be related to impaired energy metabolism, think mitochondria, chronic oxidative stress, remember that's smoke related to inflammation, and DNA damage. That could be from oxidative stress, it could be from toxins. Surprise, surprise, I'm saying the same thing again. It's just a different organ that's vulnerable. So in Alzheimer's, it seems it's a form of diabetes that selectively involves the brain. It's just the organ that gets damaged. For me, it was my ovaries. For somebody else, it's breast cancer. For somebody else, it's fatty liver. For this person, it could be Alzheimer's. And what it is that the brain can actually be insulin resistant. It's a peripheral organ that can develop insulin resistance, and it can happen in the absence of hyperglycemia outside the brain. So just because you see normal blood sugars in your lab testing, it does not mean that the brain cannot be insulin resistant. So you want to look around for other clues. Reduce the inflammation, reduce other signs of insulin dysfunction. Remember, blood sugar is very late. It'd be interesting to know if they checked fasting insulin, if that was related to insulin resistance in the brain, right? So, surprise, surprise, if you take good macronutrients, you can reduce the risk of mild cognitive impairment or dementia. So think cardiometabolic food plan, everything that Michael has been teaching you. And consider that these cognitive decline issues are largely driven by metabolic dysfunction. And when I say metabolic, I want you to consider insulin as one of the big metabolic drivers, okay? So here you are. I'm hoping that you're shifting your thinking when you're looking at these diseases. That when I talk to you about metabolic syndrome or inflammation and insulin resistance, or just insulin dysfunction, that you're not just going to go to type 2 diabetes or heart disease. That's so old conversation. The new conversation knows that the same drivers affect a whole host of other phenotypes, all commonly rooted in those simple things: inflammation, insulin, and toxicity. So we're on to our final stretch here. We are going to design some personalized functional treatment plans. Okay, so remember, you always have to use the timeline and the matrix to kind of help you know, where do you start with this patient? And for some people, it might be you're just going to tweak a little bit of lifestyle because all they're working on is changing their body comp. Or you might be with that patient who shows with a hemoglobin A1C of 13.2. And that person, I had to add pharmaceuticals, nutraceuticals, and lifestyle. I had to throw the whole kitchen sink at him, right? Just meet them where they're at along the continuum of their dysfunction. So if you're wondering, what can I be doing? Well, you can certainly order emerging biomarker tests to give you a sense of what organs are in play. Like what's going on with the liver? What's going on with the fat? What's going on with inflammation? What's going on with the hormones? What's going on with the cholesterol? See which organs are being affected, okay? And remember that insulin rarely lives alone as the problem maker. Insulin definitely brings friends. So what can you do to keep insulin in check? Well, definitely leverage lifestyle medicine. Consider using nutrient therapy. You can see that I have some listed here whether they're testing options to further identify insulin issues or nutrients. Sometimes I'm going to tell you this, in my insurance-based world, if I couldn't get a test covered or the person couldn't afford the test if it wasn't covered, many times I would use my treatment as diagnosis. So, it wasn't uncommon that I would probably put somebody on some insulin sensitizers or probiotics. And if I saw things were improving, I'm like, oh, okay, they must have had a gut issue. I mean, I use the history in my timeline as a main indicator. And, you can call it simple medicine. You can call it really savvy medicine, however you want to call it. You can use your treatment, especially when it's a low risk and a potential for high efficacy, as a diagnostic tool. Yeah. And the way that I look at it with the patients I was serving in this little underserved area, why would I spend money on testing when I can spend it on the treatment if they had a fixed income? So for my patients, and still to this day, finances is a big consideration. A lot of the treatments that I've been highlighting are safe and effective. So you can use them to help you diagnose, if you will, in retrospect, what could be going on, right? That way you don't have to spend $300 and $400 on, microbiome evaluations. I do elimination diets to help me figure out food sensitivities and food allergies. There's just cheaper ways to do it. It might be a bit more arduous, but it's just as effective in many ways. All right, so remember to continue to use this decision tree, and always remember to track your responses. You don't just throw things at people and then hope they do well, of course. With breast cancer, here's a few modifications. I really like to improve estrogen detoxification because they have a high estrogen state. So I want to maybe sometimes use botanicals that help improve estrogen metabolism. I want to make sure these people poop, because one of the best ways to get estrogen out is through the colon. Again, ask them if they're having a soft toothpaste stool that ballet dances into the toilet bowl without any splashing. That, and if you can do that and it happens on its own and it doesn't require effort from you to squeeze it out, that's a good sign that your bowels are healthier. If not, use your different tools to get them to poop, and obviously reduce toxic burden. For PCOS, detoxification is another big part of what I do in addition to reducing inflammation and insulin resistance. Many times for my patients with infertility, I will partner with an acupuncturist in order to help calm the HPA axis down. Yeah, because we want to restore ovulation and improve that mental, emotional, spiritual node of the system, of the matrix. So here's a summary of some of the nutraceuticals you can consider with what their mechanism of action is. It's a cheat sheet for you. Remember, you're going to try to work against the insulin resistance, reduce inflammation, optimize energy, and detox. Yeah, those are kind of the categories that you can think about. And here's what I really do. Okay, in my living, breathing practice, it's always about food first. But I think, what kind of food? Do I want to kind of start with a detox, or do I want to start with cardiometabolic focus? Now, here's the thing. It's irrelevant what I think I want to do, because guess who's the one who's got to do it? The patient. So really, I kind of determine what I think is the initial big picture need. And then when I do my tell back to the patient in the go-to-it model, I'm actually asking them, hey, listen, you think you could do an elimination diet? Because I'd really love to do that and to improve detoxification. Notice this is one of my secrets that I believe makes a big difference for my patients. I don't do the elimination diet and then do a detoxification program. My thing is, well, if we are having you do the elimination diet, let's do the detox at the same time. Why make you do a restrictive diet twice? Let's do a 2-for-1 special and really reduce inflammation with the the elimination diet, and get the garbage out with a good biotransformation and elimination protocol. So I try to control, I'll delete with a detox and elimination diet from the get-go for most of my patients. But if they're like, my daughter's wedding is coming up, there's no way I'm going to go gluten-free, dairy-free, sugar-free, this-free, that-free. I'm like, okay. Then I would promote that we do the cardiometabolic like maintenance plan until you can do the control, alt, delete of the detox and elimination diet. Okay. So you're really trying to figure out, like, does this person want to be a hare or a tortoise about their next steps. Many times people who come to see me, they're like, tell me what to do. I'm desperate. I'm ready. So there is a group of people that are like, not right now. Those people, I would have you go through the cardiometabolic focus. It's a great maintenance and slow but sure cleaning up process of insulin and inflammation. You use the cardiometabolic food plan. It's got, as Michael has talked about, recipes, weekly planners, shopping guides, all this kind of stuff. And then a maintenance plan. But when they are ready to really clean out their closet, because this is what I'm looking for, like they come to you with this huge, messy closet, and I'm trying to get this place cleaned up and sorted, kind of like a Marie Kondo of their body. Well, that's when I really, like I said, start with people with this detox/renew as the IFM food plan and process. So this is my plan that I do. I start with what I call a preload. It's basically practicing the elimination diet and the detox diet or the renew diet. And I'm just having them figure it out. Like, oh, how am I going to eat dinner? How am I going to eat when I go to my mom's house? Or what am I going to do during soccer practice? They're just practicing. But what's real nice during preload is it's warming up the detoxification engines. So they're less likely to have those detoxification reactions from kind of moving things too quickly. Then I put them into a 4-week elimination diet. Okay, like the actual 4-week elimination diet. And even one of those weeks, I'll recommend fasting with liver supportive veggies. Okay, I generally make it the last week because they're kind of professionals with this at this point. And it's kind of like this super duper detox week. And then I teach them how to do a single ingredient reintroduction so they can figure out which foods were their inflammatory triggers. That's how I do my plan with most every one of my new patients. Those are generally people who want to get all hair about it, like they are ready to zippity doo-dah into health. Okay, so what I want you to consider is use the toolkit. You have so many things there that can make a difference for your patient. And you don't have to be the person who gives all of the information all of the time. Let the tools do the work, okay? So consider when you go food first to pick either that detox elimination combo, that hair, like let's go, let's get dirty and let's get clean quick, or let's do the cardiometabolic food plan first for a bit until you're ready to take on the detox and elimination diet. Now, why do I even say until you're ready? I'm gonna just tell you that most people who have never done functional medicine generally need to support their liver and reestablish a healthy microbiome. It's just so rare. Even people who do things on their own, many of them do elimination diets, but they never did the detoxification, or they do the detoxification and they never did the elimination. And it always reminds me of TAC theory, right? So TAC theory, if you're sitting on 10 TACs, and then you remove one, and so you remove gluten. The patients who read something and they said, I removed gluten and it made no difference. Well, yes, because you're still sitting on 9 other TACs. So what they do is they put the gluten back in their bottom, and then they say, maybe it's dairy. So they remove the dairy TAC and they're like, nope, it's not dairy. Again, there's 9 other TACs still in your bottom. So when you do the detox with elimination diet, you not only clean up a lot of the symptoms people feel with fatigue and brain fog, energy, headaches, like pooping, we get that all cleared up in addition to reducing all the inflammation from the microbiome. And they actually pull out enough TACs all at once that they can see oh, something that I did made a difference. And then through the process of the reintroduction, they're putting each ingredient back in, and they're seeing corn. Oh, okay, that wasn't so bad. Okay, corn must not be one of my TACs. But sometimes they'll put back in, some sugary drink, and they're like, oh my goodness, I had such a headache. And I'm like, well, you just got used to those frappuccinos, and your body was so affected by it, but it almost maladapted to it. So now they have this awareness oh, this is what sugar does for me, and so on and so forth. So employ TAC theory and get, if you can, a time in their life where they're able to do the detox and elimination diet at the same time to control, alt, delete their system. They can't do the cardiometabolic food plan doing a slow but steady cleanup of the inflammation and insulin signals. Movement, essential. I'm going to talk more about it in my exercise portion. And the other thing that's really important that I haven't really focused on here, but it's worth mentioning, is that sleep apnea is another driver of inflammation, and it's associated with diabetes, blood pressure, right? And a lot of cardiovascular risks. So really take a good sleep history. Do you have to do this all on your first visit? No, you can't. I mean, for most of us, we have limited time. So I make it a point to just focus on the main drivers. I always want to make sure the liver and the gut are taken care of, and I'm looking for sources of inflammation. I'm asking about the stress in their life, and sometimes that's where I have to start. I'm looking at their support systems. What is the social determinants of their health that I need to potentially support them with, right? And for me, it is so important that your patient has their inspirational why, what another faculty member calls the philosophical why. Like, why do you even want to get your diabetes in control? Why does it matter to you that you don't have a heart attack? And then let them tell you, well, because I love my grandchildren and that's why I'm doing it. And see, as you're moving through, when they're like, do I have to eat another serving of broccoli because I'm going to kill you? That's when you say, hey, remind me again, what's your inspirational why? And they get reminded to what they're committed to. And that helps them maybe pass over that threshold. It doesn't work all the time, but I do think it makes a difference that they're doing the program because of their why, and they're not going through just the what of the functional medicine treatment plan. Like, what do I have to do? How do I have to do it? When do I have to do it? It's not inspiring for people. When they know their why, the whats and the hows and the whens become less significant. Remember that having that connection to that purpose or that why is one of the biggest tools you can use to increase compliance, especially to people who are new to this. Targeted nutraceuticals. Remember, I talked about how you want to always pick from the list and find things that would be like a buy one, get one free. So if probiotics would help the gut and help inflammation, and help IBS, pick probiotics as one of your first things that you start with, right? So what I want to say is functional medicine is so much about personalized medicine. So everything that I've taught you is just how I found it to be useful as a template. But I also trust that there's more than one way to do something. It's just my intention to give you somewhere to start if you don't have a place that works for you already. And again, I invite you to continue to think that the real voyage of discovery consists not in seeking new landscapes, but in having new eyes. I hope after this lecture, you have new eyes about inflammation, insulin, and toxicity, and how it is at the root of so many conditions that your patients are facing, and how through very simple and effective lifestyle and nutraceutical interventions, you can change that signaling and really change the course of their symptoms today and the risks that they have tomorrow. Thank you so much again for your attention. I'm looking forward to another fabulous day with you. We're excited. The whole team is ready to go today. Thanks again, and we'll see you next time.